To call on Dr. Dipanjan for the next topic, which is on neuroprotection and glaucoma. So there has been a lot of noise for years about neuroprotection, and even though we have a few drugs which claim to have neuroprotective properties, we are not really sure about how to proceed. So I hope Dr. Dipanjan is going to shed some light into this controversial topic.
Hello. Good morning, everybody, and thanks Origin for including me in this IC. So glaucoma is the most common optic neuropathy, and there is progressive degeneration and death of retinal ganglion cells, and degeneration is widespread from retina to visual cortex. But unfortunately, lowering intraocular pressure does not address this retinal ganglion cell's susceptibility to degeneration. So our new approaches to therapy in glaucoma that we will revisit currently available anti-glaucoma medication that offers neuroprotection, and then we switch on to discuss the next-gen therapeutics which aims at retinal ganglion cell survival, protection, and rebuild neuroconnections to retina, and we will start giving some new concept about neuroenhancement. So when you talk about glaucoma, that events leading to RGC cell death, it is either damage to RGC survival pathways or the triggers of apoptotic pathways. So either it starts from mechanical pressure at lamina cribrosa, or it's an ischemia or genetic factors, ultimately leading to obstruction to exoplasmic flow, and it depletes the neurotrophic factors that are supposed to maintain the health and nutrition of the retinal ganglion cells. Or otherwise, there is a glial cell activation in retina and lamina cribrosa that release neurotoxin, which cause a glutamate excess and causes an NMDA receptor activation. And there is excessive calcium influx into the cell. The calcium is very damaging to mitochondria, and there is disruption of mitochondria and production of caspases, activation of proapoptotic genes, and inhibition of anti-apoptotic genes, which ultimately leads to the death of the RGCs. And unfortunately, when a group of RGCs dies, there is a neighbor kill effect, and ultimately there is progressive or secondary injury to the other RGCs. DARC or DARC is it is detection of apoptizing retinal cells, which has come recently, which is a real-time visualization of apoptotic changes at the cellular level. And we know that there is early exposure of phosphatidylserine in the outer leaflet of plasma membrane of apoptotic RG cells. And annexin V is a particle which has high affinity for this phosphatidylserine. And annexin V, when it is leveled with a fluorescent marker, and this complex, which is called a fluoroprobe, is injected intravitreally, and the retina is scanned with an argon laser of 488 nanometer. And these specific areas are excited, and there is a confocal laser scanning ophthalmoscope is used to assess the retina for these fluorescent white spots, and which represents apoptotic RGCs. So if we can have this, it will be possible to identify these group of patients prior to irreversible visual loss, and will provide a rapid and objective assessment of clinical intervention, and will also shorten the period of clinical trials. So we know very well about brimonidine, and there has been multiple publications on its effect in NMDA receptor activation or glutamate excess pathways and things like that. But it is been proven mostly in animal trials. But LOGS trial, this is low pressure glaucoma treatment study, and this is the first randomized double-blind 4-year study that actually compared the visual outcome in low pressure glaucoma patient with brimonidine and timolol, where primary endpoint was visual field deterioration. And in the key outcome, there was statistically fewer brimonidine treated patients had visual field progression by point towards regression than timolol treated many patients. But are we really there? As we see from the study that there was significant dropout in the brimonidine group that was amounted to almost 20%. So there may be a group of patients who were actually progressing but were not detected in the study. And the subjects in the both groups were actually undertreated. And then with the same group, Dr. Moraes and all, when they saw the basic and intercurrent risk factor, how they actually affected, the study, and they saw the neuroprotective effect of brimonidine was unrelated to its eye-prolonging property on change in ocular perfusion pressure. So the current approaches for neuroprotection would be either rescuing these damaged retinal ganglion cells, or there are strategies to improve the optic nerve head perfusion or optic nerve degeneration, regeneration. So there are some new agents to improve optic nerve head perfusion. Apart from the group of dorzolamide what we have seen, there are some ROCK inhibitors that have come, that is going to come. Either in topical application, one ROCK inhibitors have come, but we are not very sure whether it is actually, they have not claimed about this ONH perfusion part. Something is going to come as an intravitreal injection. There is cannabinoid receptor agonist, and there is centrally acting calcium channel inhibitors like nimodipine, lomerazine, and flunarizine, etc. Neurotrophins is a group of drugs that is supposed to rescue the damaged retinal ganglion cells. And if we apply exogenous neurotrophic factors, it can actually prolong RGC survival in vitro, which has been experimented in vitro in animal studies. Neurotrophins have also been tried in ALS and Parkinsonism patients by the name of BDNF or GDNF. The strategies for sustained endogenous expression of injected growth factors, and they are named as this transfection of growth factor genes into RGCs via viral vectors. So the actual challenge is if we transfect the RGCs in vitro or in vivo by various neurotrophins, the actual challenge would be whether these neurotrophins are going to then to repopulate the RGCs. So that there lies a real challenge. Then we can actually stimulate the RGCs with electrical activities by putting more calcium into the body. The X-linked caspase inhibitor is also currently under trial for NION. There is transplantation of stem or progenital cells. The challenge is not there. We can transfect the cells into these stem cells there, but whether the new RGCs are going to repopulate from the stem cells, there lies the actual challenge. So this is another beautiful thing. It has been it is a neurotrophin secreting device which is called Renexus from Neurotech USA. This secretes CNTF. This device is being implanted in pars plana and stays for life, and it has undergone phase 2 trial in patients with retinitis pigmentosa, and it is currently under trial for POAG. It is recruiting patients. This may be a hope. And coming to the last part, the holy grail, that is the optic nerve regeneration, and this actually works in two ways. That blocks the inhibitory signals and intrinsic growth ability, or there is cell transplantation. So that we know that the glial tissue release inhibitory molecules that actually signals RGCs to stop growing. So we need to do something or develop something that actually inhibit these inhibitory molecules. So one of them is NOGO, which is being investigated for spinal cord injury. As is Kethrine, this is one of the ROCK inhibitors, and that inhibits signaling pathways with RGC nexons that mediate these top 6 signals. These molecules could be tested for an ability to degenerate optic nerve axons. And there is the other part, this is enhances intrinsic growth ability, or the holy grail. This is stem cell transplantation that has been shown to enhance RGC axon survival when injected intraocularly in experimental model. And then the real part is that the actual challenge is to transfer this injected cell into the real phenotype. Neuroenhancement is a newer concept which targets a therapeutic window between dysfunction and death of retinal ganglion cells. It's a kind of treatment that actually improves RGC health and function, supposed to be a promising tool which can shorten the time scale of therapeutic trial. The examples are neurotrophins, citicoline, or transcorneal or transorbital electric stimulation. So to conclude, IOP lowering will remain as primary neuroprotectant, and there is enough motivation to move towards complementing intraocular pressure lowering. Further research is happening towards overcoming the need for IOP lowering, and neuroenhancing with newer neurotrophins really hold promise. Thank you.
Thank you so much, Dipanjan, for that wonderful talk. So like I mentioned before, there's a lot of noise regarding neuroprotection, neuroregeneration, neurorejuvenation. So you'll see these papers which are coming out, which have a lot of these names. But I would like to ask the speakers whether anybody really uses a drug as a neuroprotectant, or let's say citicoline, something as a neuroprotectant, or is it still IOP lowering all the way?
From my side, when I'm choosing the drug, I choose a drug which has got some, like for example, prostaglandin analogs, bitoxolol. If I have a choice, if I see the patient's a bit bad, if I have to choose one, I tend to prefer one which has got some propensity towards protection, but I'm not using specifically for that. But I tend to slowly prefer towards drugs which have that also, because we all realize now that it's a very important, neuroprotection is important also. So we try to go and then also look for other factors like, hypotension, like how he rightly pointed out. So we have to have a balance. So not only the intraocular pressure, we're slowly focusing towards having the posterior, the optic nerve head kind of perfusion, and what we can do at an early stage itself rather than waiting for an advanced stage. So it will slow down the decline of those glaucoma patients. So I tend to do that actually.
I heard a talk by Dr. Alan Harris in Kolkata, and he showed how in his lab he has really done extensive studies and proved that dorzolamide has a big role in vascular protection, vascular flow and neuroprotection. So since then, whenever I am dealing with a query in TG or where I think I want to add on a neuroprotection, I prefer that drug.
Right. And Dr. Dipanjan Pal had shown that wonderful slide on DRC, where nowadays in real time, you can see the death of the apoptotic cells, which fluoresce. So probably that will give us more idea, and in the future, the treatment advances. Please, sir. Yeah. Yes, that's what I wanted, because citicoline, they claim that, give a 45-day constant treatment, then a break, and then another 45 days.
It has been shown promises on PERG. It has not, in pattern ERG, it has shown promises when at least you have to use 2 years. And the thing is, for first 3 months, if you use in a very high dose, that is at least 2 to 4 tablets or capsules, whichever way they have. If you ask the patient to take, and you can ask the patient when he is having some kind of improvement in his life, okay? Because most of the time they have lost contrast. They cannot see things clearly at night, okay? So citicoline sometimes improves as per patient's view. When I use citicoline in 10 patients, at least 3-4 patients, they say that they have some kind of improvement. They have some better vision in low light, and they have a little better contrast. So definitely, sorry?
Subjectively, many of them?
Yes, subjective improvement is a big thing for them. And primarily I was thinking probably, patient have a thing like if I have given something, they feel that it is a psychological feeling. It is not like that. It is not like that, because many patients say that yes, I have some better.
One take on that. Actually, if you see the published literature with citicoline, with ginkgo biloba, curcumin extract, there are articles in PubMed where they've shown that there have been visual improvement and all. But these are controversial areas. The costs are involved. You have to give for a long time. So in these cases, I personally prefer to go by the standard guideline like the EGS or AO or even the World Glaucoma Association consensus, which have very clearly mentioned that they are not proven. So if you want to use it, but they are not proven. So it's like a placebo only.
Right.
So
Thank you. Thank you.
Thank you. Brimonidine has actually improved their visual fields. Have you documented it? That brimonidine has actually improved their visual fields? Visual feels like the patient feels a subjective difference.
Actually, that's what the LOGTS study had said, but there
can
were a
be
lot of
learning
flaws
curve
in that
also.
particular study. The visual fields
Okay.
had a lot of flaws, but ma'am is kind of reiterating the same thing. So probably there is some truth to it.
There is a truth to it if we consider the acute phase of disease.
Yeah.
In that one of my slides I showed that neuroenhancement. That particular thing can happen if the patient comes with a really high intraocular pressure and you lower down the pressure, you can definitely have a immediate improvement in visual field that can be documented.
Thank you. Thank you so much, Dipanjan. So I'll move on to my talk, which is about the vascular factors in glaucoma.